Hello. Again, my name is Lusana Schutz, emergency medicine physician and clinical instructor at Stanford University Hospital, and I am presenting this case on seizures. We are now on to part 2 of this case, and if we recall, this case involved a 25-year-old man who was brought in by his family with complaint of unresponsiveness and jerking movement of his body, starting about 10 minutes prior to arrival. On initial assessment, we recognized that the patient was unresponsive and had jerky movements of all of his extremities. He had abnormal vital signs, including tachycardia to a heart rate of 125, tachypnea, 32 respirations per minute, and hypoxia of 89% on room air. He was afebrile, and he had a normal glucose level. Our initial interventions to stabilize the patient includes placing a nasopharyngeal airway, providing supplemental oxygen, getting IV access, providing IV fluids, and placing the patient on a monitor. We initially gave him 2 milligrams of IV lorazepam, and on evaluation it seemed that his jerking tonic-clonic movements had stopped, his vital signs had improved, and he seemed sleepy but was arousable to some painful stimulus. We go back to our emergency medicine approach. We did our initial assessment, which was evaluate, think, and act, and we acted on any abnormalities we saw in the airway, breathing, or circulation to assure that he was getting oxygen delivery and stabilizing him initially. We then go on to our re-evaluation, thinking and acting again, and this is the next segment of our management. If we review our 4 goals of seizure management, again, the first was assuring oxygen delivery by addressing the airway, breathing, and circulation, stopping the seizure activity as soon as possible. Now we go on to diagnosing and treating the cause of the seizure and for preventing further seizure activities. Right now we're going to focus on diagnosing and treating the cause. The emergency medicine approach of re-evaluation, thinking, and acting is equivalent to our diagnosis and treatment of the underlying cause of seizure. First, we'll start with a sample history and focused physical examination now that our patient has been initially stabilized. In the sample history, if you remember, we want to obtain symptoms, allergies, medications, past medical history, when the patient had a last meal, and events leading up to the episode. Remember, if the patient is unable to provide their own history, such as our patient, then try to obtain information from family, ambulance staff, bystanders, or others around. For our patient, we were unable to obtain symptoms from the patient because he is still sleepy after a seizure. Family member has noted that he has no allergies that are known. He takes no medications regularly. As far as past medical history, he has no ongoing medical problems. There was no head trauma prior to the accident, and they don't suspect any type of intoxication or drug use. His last meal was last night, and as far as events leading up to the event, there were none to be noted. Other things that you'd want to ask about in the history may be, again, preceding symptoms. Did the patient have a fever? Has he been ill recently or had a cough? Was there any type of hypoxic event, such as a near drowning episode? For our patient, we didn't obtain any of this in the history. Family did not confirm any of these things. If a patient has prior seizure history, which our patient does not, you'd want to know about baseline seizure pattern, medications that they take, if any, and if they've had any possible toxicologic exposure. As far as character of the seizure, you want to find out about details of the character. So for our patient, it lasted about 10 minutes. There was tongue biting. He has a laceration to his tongue. There was incontinence. These support the diagnosis of seizure. He had tonic-clonic movement, which did not seem to be focal, and it appears now that he may be in a post-ictal period. So it's good to get information about the character of the seizure. This can help us try to understand what the underlying cause is. As far as our evaluation, we want a focused physical examination. This can help us look for reversible causes of seizure and or other underlying causes of seizure. Particularly important in an evaluation for seizures is to get vital signs and glucose, of course, during the initial assessment. Look for any evidence of trauma or any history of trauma. do a thorough neurologic exam, and look for any signs of infection. For our patient, on head exam, there was no evidence of trauma. From the mouth, there was tongue biting, which supports the diagnosis of seizure. For the neck, his neck was supple without evidence of meningitis. His lungs sounded clear. We were looking for possible infection or signs of aspiration, but there was no obvious signs on our exam. The abdomen, there was no guarding or distension or other evidence of acute intra-abdominal process. There's no swelling, injury, or other abnormalities to the extremities, and there were no rashes on skin exam. As far as our neurologic exam, the patient's mental status now is sleepy, but he moans and moos to painful stimulus, which is improved from when he arrived. His pupils are equal and reactive bilaterally. His motor activity, he moves all extremities and seems to have equal strength in all four extremities. He has no automatisms such as lip smacking or chewing. There were no focal deficits that were obvious on when he had seizure activity and after the seizure. And his Glasgow Coma Scale is 9 at this time. Next on our emergency medicine approach, we've done our reevaluation, such as obtaining sample history, focused physical exam. Then we go on to think about our differential diagnosis. What could be the cause of this patient's seizure activity? Well, the differential diagnosis for seizure is broad. You can have primary seizures or idiopathic, which may be recurrent seizures without an obvious known cause. Secondary seizures, there's many different causes. So there could be infectious causes such as TB, neurocysticercosis, meningitis, encephalitis, cerebral malaria, HIV, brain abscess, syphilis, or febrile illnesses. Metabolic causes such as abnormalities in glucose, sodium, calcium, magnesium, renal failure, or thyroid disease. Anatomic abnormalities. It could be after a traumatic injury, so traumatic injury to the brain, a cerebral vascular accident, an AV malformation, a tumor, or a vasculitis. It may follow a hypoxic or ischemic event, so such as a drowning, or in children, apparent life-threatening event. Toxins could cause seizures such as sympathomimetics, INH overdose, insulin, or medication non-compliance if a patient has a seizure disorder. Also not included on this list, but to be considered in pregnant women, would be eclampsia. So we are thinking about all the things that could cause our patient's seizure. And then our action in this cycle is to perform diagnostic testing and any therapeutic interventions. So for diagnostic testing, I'm going to say this over and over again, but very important to check a glucose on all seizure patients. Labs that you might consider, and I would recommend on all seizure patients, would be electrolytes, BUN and creatinine to assess renal function, a complete blood cell count, a urinalysis to look for infection. You may also consider on certain patients a creatine kinase if the seizure is prolonged, a pregnancy test, a tox screen, and anticonvulsant levels for patients that are taking anti-epileptic medication. Head CT should be considered on certain patients. I'd get a head CT on any adult that's having a first-time seizure, patients with head trauma, history of malignancy to look for any metastatic disease, a patient with focal seizures, so just maybe a seizure in one extremity or one part of the body, persistent headache, an abnormal neurologic exam. You may also consider doing a lumbar puncture on patients that have persistent altered mental status and those that you may suspect a CNS infection or suspect a subarachnoid hemorrhage. So these are all diagnostic testings that you would consider doing on your patient. You may not do on all of them, but for our patient, we get electrolytes, renal function, a CBC, urinalysis, and a tox screen. We do a CT scan of the head. Electroencephalography may not be available at all facilities, but patients that need an EEG or should be considered for transfer for an EEG are those that have persistent altered mental status or those that have had persistent seizures and required paralysis or barbiturate coma, or some type of general anesthesia to suppress the seizure activity. These patients may have ongoing seizure or status epilepticus and need to have an EEG done to confirm this. I said, I'm going to say this over and over again, make sure to check a glucose on all patients immediately. This should be done with the vital signs. Again, this is an easily reversible cause and a life-threatening process. So as far as the evaluation, for our patient, our diagnostic test results show a glucose of 128, a CBC just with a mild leukocytosis, which is nonspecific. A chemistry shows mild hypokalemia, but otherwise the electrolytes are within normal limits. Urinalysis shows no infection, and the toxicologic screen is negative. We get a chest x-ray to evaluate for infection or signs of aspiration, and our chest x-ray is normal. We get a CT scan of the head, and this is what we find. I hope you can all appreciate that there are multiple lesions in the brain on both sides, those circular white lesions. This is certainly abnormal. So we're thinking and putting together all the information that we've obtained. We have a patient that comes in with seizure. There's no history of head trauma, and we can't find any rapidly reversible causes for the seizure. And then we have a CT scan that shows lesions in the brain. So that's where we end this part of the case. The summary for this section: use the history and physical exam to look for the possible causes of seizure. These could be easily reversible causes or signs of trauma, infection, or other disease processes. If unable to obtain a history from the patient, attempt to obtain it from somebody else, from family, friend, bystander, or another person. The differential diagnosis for a seizure is broad, and think about all the different things that could be causing your patient's seizure. And the first-time seizure may require an extensive workup, as you've seen, with labs, a CT scan, other imaging, and maybe even EEG. Thank you very much for participating in this section of our case.